Hi everyone, it's Dr. Charlotte Hodges, and today I wanted to talk a little bit about an uncomfortable subject. That subject would be how to deal with complications after weight loss surgery. Certainly as a surgeon, we do everything that we can to optimize our patients prior to surgery, give you good preoperative education, offer you a good, safe surgery, but even the most compliant patient or even the best surgeon at some point may have a complication. And it can be very difficult for the patient, for the family. Also even for the surgeon. None of us want our patients to do bad. And so I wanted to talk a little bit through the types of complications that a patient may encounter, and then basically the treatment and how to deal with it and how to get through with it. Because I will tell you, even though my patients may end up going through a valley, they're going to come through that valley. They're going to be at the mountaintop at some point. And I always try to reassure them for that. So let's start talking about some of the smaller complications, and then we'll go to the bigger ones. So the more common complications that we might encounter. So it's not uncommon for me to have a patient a couple of weeks after surgery, a month or two after surgery, to be complaining of nausea. What is the most common cause for nausea? It is certainly going to be your protein intake, 9 times out of 10. If I have a patient that's coming to me and they almost feel like they have morning sickness all the time, sometimes even they get to the point that they're nauseated, but they can't even physically get water or soft foods down, the first thing I have to look at is, what has their protein intake been like? And if they are not compliant with their protein, so if you're a bypass or a sleeve and you're not getting in your 60 to 80 grams of protein a day, or if you're a duodenal switch or a long limb bypass and you're not getting in your 100 to 120 grams of protein a day, you will certainly start having those issues with nausea, that feelings of morning sickness. You'll have some fatigue. You might even feel very achy. And the way that I best treat that for my patients is I give you a slew of anti-nausea medicines, usually 3 different ones, 2 that are oral and 1 is a little patch that you put behind your ear. And then I have my patients just start slow. I encourage them, try to get maybe an unflavored protein powder. DocHaleNutrition.com as well as Gene Pro are 2 really good unflavored protein powders. They dissolve completely in liquid, so they can put that in their iced tea. They can put that in low sugar juice. They can put it in a liquid that they like, not necessarily having to make a great big thick protein shake. And I tell them, this didn't happen overnight. It's not going to go away overnight. But generally after about 2.5 weeks, as they're consistent with getting their protein in, their nausea symptoms will certainly improve. So what happens if I get a patient that comes to me, they're maybe 3 weeks out from surgery, 4 weeks out from surgery, they're having some nausea, but they're also having some difficulty swallowing. At that point, I'm not just concerned about, are they non-compliant with their protein? If they're about 30 days out or so from surgery, the other question I have is there narrowing or a stricture in their surgery? So I typically don't see narrowings with a sleeve. Where I generally will see these strictures are with a duodenal switch or with a gastric bypass. And the reason is there's a circular staple line that connects the stomach to the small bowel. And that circular staple line, just as how physics works, it's just a little bit more prone to kind of scar in. Things that can cause patients to get a stricture would be if they're preoperatively, if they're anemic or if they're a little malnourished, if they're a smoker, if they take any NSAIDs like ibuprofen, Aleve, naproxen, naproxen, if they're on a steroid. These are all things that can kind of inhibit the healing and cause patients to develop a stricture. The other thing that can develop strictures is if they advance their diet too soon. Typically, if I see somebody after their 1 week follow-up and they tell me, yes, I did do broth, but I also tried some chicken and it went down really well. I chewed it up really, really good, I promise. 9 times out of 10, I know when I see them for their 1 month follow-up, they're going to be complaining of some dysphagia, which is difficulty swallowing, and I need to kind of do a workup on them for a possible stricture. How do you get worked up for this? Some surgeons might do an upper GI, and that's where you just drink some contrast and they'll take a little x-ray of your belly to see if there's any narrowings. What I prefer to do is I usually will just go ahead and set the patient up for an EGD. What that is that's an upper endoscopy where I put a camera down their mouth and I'm going to look at their esophagus and stomach. And it kind of kills two birds with one stone. If I go down and I see that their anatomy is fine, then I know that their nausea, vomiting, and maybe their difficulty getting foods down, that is just all nutritional, and I just set them up on that regimen of anti-nausea medicines and have them really work on their protein. However, if I do see that there is a narrowing at that anastomosis or the hookup between their stomach and small bowel, then with the scope, I'm able to go in with a balloon, and then I'm able to dilate up that opening with the balloon, and then they're able to tolerate their liquids and soft foods after that. Patients may need anywhere from 1 to 3 dilations depending on how tight the stricture was and also how compliant they are after the dilation. I will typically put my patients on a liquid diet for 2 weeks after their dilation. Now, some GI doctors are a little bit more aggressive, but I've just found in my practice that I like to be more conservative, because if I can get away with maybe just 1 dilation as opposed to 2 or 3, that's always better. So we have nausea and vomiting, we have stricture. I sometimes may see a stricture in patients or those feelings of difficulty swallowing even 6 months out from surgery, a year or 2 out from surgery. And these are patients that have been given maybe ibuprofen, a Medrol dose pack, that's like a steroid pack because they've had an upper respiratory infection. And they're so far out from surgery that they're not even really thinking, oh, do some of those rules apply to me? And they always will apply. So it's not uncommon for me to see in the fall when flu season is around for patients to present to me with symptoms of difficulty swallowing because maybe they've been given a Z-Pack, so an antibiotic for an upper respiratory infection, but then they've also been given a steroid, and then that in turn can cause an ulcer, and as that ulcer heals, it scars in. They're treated the same way as somebody that's early on from surgery, that we do an EGD and we do a balloon dilation on them. Now, those are relatively harmless types of complications, and it's not unheard of. Another complication that patients can have is maybe the first week or 2, patients can get a little dehydrated if they're not keeping up with their fluids. Typically, the only intervention that a patient may need is just getting some IV fluids. A lot of times they can get that in a local ER or one of the care nows. At some of the facilities where I work, we even have an infusion center, so patients just can come in, we give them a couple of bags of fluid, they end up feeling like Superman afterwards, and then they're able to go on about their way. But what happens if you get one of these more significant complications, such as a leak, or which is an opening along the staple line, which can also lead to an abscess? What do you do then? How are these treated, and what's the recovery like? And I will tell you, certainly no patient wants to get a leak, and absolutely no surgeon wants to have a leak. And luckily, the leak rate for bariatric surgery is very low. It's less than 0.6% now nationally. You kind of treat leaks differently depending on when they present. If it's in the immediate postoperative period, so within the first 24 to 48 hours, you certainly will see a patient that will have a high heart rate. They might have increased abdominal pain, kind of more so than what we would typically see with a postoperative patient. And that's diagnosed by having them drink some contrast, and we'll get a CT on them. If we see that there is a leak, if it's within the first 48 hours, we most certainly will take them back to surgery, go in, see where the leak is. We will oversew that area. Sometimes we do what's called an omental patch, where we take a little piece of fat, kind of patch over it. We might keep them in the hospital the next couple of days, do another couple of swallows studies on them, make sure that there's no leak, and then they can go on about their way. Those are the optimal types of leaks to get because those are a much easier fix. But what do you do whenever you have like a subclinical leak? So one that happens maybe 4 to 6 weeks out after surgery, or what happens if it's somebody that's 2 years out from surgery, they've been given a lot of NSAIDs or they've been given steroids, they develop an ulcer, and now that ulcer it's popped. Now what do you do? And there's several different things, and it also depends on the type of surgery you've had. If a patient has had a gastric bypass or they've had a duodenal switch and a hole is occurring between the stomach and small bowel, we usually will need to take you back to surgery. We will do what's called a little Graham patch if we can. So do a little dissection, put a little piece of omentum up there. We generally will leave drains. If there is an abscess there, which is like a pus pocket, we'll leave a drain there too. And those will usually heal a lot quicker. Oftentimes, whenever patients will have a perforation, we'll put a special IV in them so they can get IV nutrition. And they may need to have that IV nutrition for several weeks. And unfortunately, these patients are not able to have anything to eat or drink, maybe have some ice chips. But while that thing is healing for the next couple of weeks, they can't have anything by mouth. Sleeves, on the other hand, are generally much more difficult to heal because a sleeve itself is pressurized. If a sleeve is going to leak, it's usually at the upper portion of that sleeve. There's several different ways that those can be treated. You can put a patch on those. You can leave a drain. In my facility, there's a GI and colleague that I use actually at Baylor University Medical Center, and he's kind of pioneered this one procedure where patients will undergo a series of EGDs with like a little mini wound vac where it kind of helps to heal the perforation from the inside out. Patients may also need to get what's called a stent. And what that is you have a little device that's placed with the endoscope, with that scope, and like a little plastic sheath is placed on the inside of the gut to kind of hole over, almost like a little bicycle patch, so that tissue can heal. There's just several different ways that perforations can be taken care of. I think the major downside with a perforation is that if patients present with a large abscess, they can get very sick. They may need to be hospitalized for several days. Depending on their current health status and how sick they are, they may even be in the ICU. They might need to be on IV antibiotics for a while. It's usually a lot easier to heal if an abscess is not involved. If you've had your surgery at a smaller facility, then a lot of times it's better if you can get transferred to a higher level of care or maybe at an academic institution where a more complicated leak can be fixed. So I try to go from the least complication to the worst types of complications that patients can get. The reality is that patients can get through these. Mortality rate with bariatric surgery is very low. We now have data that shows that it's actually safer to get weight loss surgery than it is to have your gallbladder taken out. Even though the road might be a little longer to recovery with my patients that have complications, I've still yet to have a patient that has had a complication, whether it's a dilation or nausea and vomiting secondary to lack of protein, or even a leak. I've yet to have a patient that 6 months down the road has told me that they regret having the surgery. They just wish that the beginning hadn't been so bumpy. So if you are a patient and you're having one of these issues, you're having one of these complications, I just encourage you, just push through, do everything that your surgeon is telling you, and you will get through that. Okay? I hope that this has been very helpful. If you've liked this video, just give me a like. Don't forget to subscribe, and please feel free to share this with your colleagues and friends. Take care. Bye-bye.